Our first speaker today is Professor Hung Kwok, who is the Departmental Head of Clinical Haematology and Clinical Haematology Research at St Vincent's Hospital in Melbourne and Professor of Haematology at the University of Melbourne. She is passionate about increasing the therapy options for patients and ensuring access to the most effective treatment that may not otherwise be available to Australians. And she has secured funding of more than $14 million towards myeloma research and is highly published in the field of myeloma. In addition to her role as co-chair of the Myeloma Working Group of the Australasian Leukemia Lymphoma Group, Professor Kwok also serves as the Deputy Chair of the Myeloma Scientific Advisory Group for Myeloma Australia and has active roles in steering committees of a number of other national as well as international healthcare bodies. So I will now hand you over to Professor Kwok, who is going to speak to us about MGUS 2 myeloma.
Thank you, Deborah. Thank you. I'm so honoured and humbled to be here, and my heart just stopped when Sandy mentioned about me hugging someone because I'm still waiting for that call from HR. Hasn't come yet, but I'm just grateful for the opportunity to vent my emotions when I need it. So for those of you who know me, it's all out there. So my job is to talk to you about MGUS to multiple myeloma, and it's just an overview because Dr. Angie Yong and Dr. Cindy Lee will then talk to you about treatment options later on. But I want to start off on a positive note. And that is, there has been a significant improvement in survival for people with multiple myeloma over the recent decades. So back in the 1990s or before the 1990s, the average survival for people with multiple myeloma is only less than 2 years. And that was the era where we only had chemotherapy. And then come the 1990s to the year 2000, we then introduced autologous stem cell transplant. And for the first time, there was improvement in survival for myeloma in the order of about 3 to 4 years. And then at the turn of the century, we then introduced new groups of drugs, the immunomodulatory drugs or the proteasome inhibitors. And some of you might be on these agents now. And these agents improve survival for people with multiple myeloma in the order of 5 to 6 years. So currently, the median survival for people living with multiple myeloma around the world is in the order of 7 years. That fact being said, this is where we are heading. We are heading to an overall survival in excess of 20 years, and we are now starting to talk about the concept of operational cure. Operational cure means you live with the disease, but the disease does not progress, so you end up passing away from something else altogether. And that's due to the number of overwhelmingly effective therapeutic agents, including immune therapies, which you'll hear a bit more about later, and small molecules. And the improvement in survival is very important because the burden of myeloma is set to increase around the world, including Australia. So this here is Australian data. Whoops. So here you go. This here is Australian data. On the left, you can see that the incidence of multiple myeloma is set to increase and is increasing over the years. The orange line represents men. The grey line represents women. I don't know why myeloma is more common in men, but it is. But the incidence is increasing. On the right-hand side, you'll see that the 5-year survival rate is increasing each year. Now, with an increasing number of patients being diagnosed and each patient living longer, you see the burden of myeloma is set to increase in Australia, and this is why it is so important that public awareness is improved. So what is multiple myeloma? I'm sure you all know what it is already, but just to reiterate, it is a cancer, a blood cancer, involving a type of immune cells called plasma cells. These plasma cells are normal cells that produce antibodies to fight infection. That's their normal job. But when they overgrow in the bone marrow, they then produce abnormal antibodies. And these abnormal antibodies are the antibodies that they are called paraprotein or M protein, and we can usually detect them in the blood. And there are various types of paraprotein. So a person can have IgG multiple myeloma, IgA, or less commonly IgD. And there are some people with multiple myeloma that only produce a component of the antibody called the light chain, as you can see there. I can't point because there's no laser here. But the kappa light chain or the lambda light chains, and so they are called light chain multiple myeloma. And if these paraproteins or light chains are present in the blood, we use them to monitor how your disease is going. So say if a person has multiple myeloma and we don't do anything about it, what happens? Well, what happens is end organ damage. So these myeloma cells, by virtue of producing various hormones or cytokines or chemicals in the body, they can eat away at the bones, causing bones to become weak. So the lytic lesions get holes in the bones and the bones become weak, and you can get fractures with very minimum trauma. And as the bone is damaged, calcium is then leached out of the bone, so you can have high calcium in the blood, and high calcium can cause various problems, including fatigue, tummy pain, tiredness, and at the very severe end, you get confusion, you get kidney failure. And of course, the kidneys are very prone to damage in multiple myeloma because the light chains that I mentioned are quite toxic to the kidneys. And these myeloma cells also actively suppress other immune cells. So a person with myeloma can be quite immune suppressive and prone of getting infections. And finally, when these myeloma cells invade the bone marrow, they leave no space for good cells to grow. So a person can have low red blood cells, that's anemia, low white blood cells leading to infections, and low platelets leading to increased risk of bleeding. Now, we also know nowadays that all myeloma would have proceeded from a pre-malignant, pre-cancerous condition called MGUS, M-G-U-S. This is monoclonal gammopathy of uncertain significance. So what is MGUS? MGUS is a situation whereby you have a population of abnormal myeloma cells, and these abnormal myeloma cells produce the abnormal paraprotein that we spoke about. But yet they're not growing, they're sleeping. And because they are not actively growing, they are technically not cancer. You'd be surprised to know that this is quite common. 5% of people over the age of 55 around the world have MGUS. And these MGUSs, they lie there, they don't do anything, they don't cause any end organ damage, so there's no myeloma-defining event. With time, these populations of cells may grow, and they can occupy more than 10% of the bone marrow, and this is when they are multiple myeloma. Now, just because they're growing, meeting the criteria for myeloma, it doesn't mean that they are awake. Sometimes they can be relatively quiescent and still asleep, in which case they are called smouldering multiple myeloma. Smouldering multiple myeloma means you've got the myeloma, but it's not causing you any harm, it's not actively growing, well it is, but it's slow, and it's not causing any end organ damage, so there is no myeloma defining event. And then with time, a proportion of these cells may grow, and a proportion of patients may then develop overt multiple myeloma, aka symptomatic multiple myeloma. And this is when, if we don't do anything about it, the person goes into trouble because there is end organ damage because the myeloma is actively growing. And then there are a proportion of patients in whom the myeloma cells leave the bone marrow, goes into the blood, and this is very aggressive. Now, upon progression, not everyone with MGUS progress to multiple myeloma. There are some people with MGUS who then progress to other blood cancers, including lymphoma, CLL, chronic lymphocytic leukemia, or amyloidosis. But the majority do progress into multiple myeloma. The risk of MGUS going to multiple myeloma is in the order of 1% per year, and the risk of smouldering myeloma progressing to multiple myeloma varies because this is a very diverse group, and the risk is calculated based on a risk score, which I'll talk a little bit about later. Now, what causes MGUS to then progress to become smouldering and then multiple myeloma? Well, the first thing to say, it's nothing that you can control, so don't go blaming yourself. But it's based on 3 factors. The first factor is there is an increasing abnormality in the plasma cells itself. So as you can imagine, these plasma cells, when they divide, the subsequent generations may harbour more and more abnormal genes. These are not the genes that you've inherited from your parents, or will you pass it to their children. These are the genes in the myeloma cells, and these genes confer survival advantage to the multiple myeloma. And then the second abnormality is within the bone marrow. See, these guys, they grow within the bone marrow. And in the bone marrow, there's like a fertile microenvironment. The fertile soil in the bone marrow is conducive for the myeloma growth. And the third thing is there's progressive immune dysfunction. Now, our immune system is the most powerful tool we have to keep the myeloma or the MGUS under control. But as the immune system becomes more dysfunctional, the myeloma may escape detection from the immune system. And later on, when you hear about treatment, you'll hear that the treatment will address each and every of these aspects of abnormality. Now, as I mentioned, MGUS and smoldering myeloma are the stages preceding multiple myeloma. So what's the difference? So this curve here shows the risk of progression to multiple myeloma. The bottom line represents MGUS. So if a person has MGUS, the risk of progression to multiple myeloma is 1% per year. It's quite stable, and you can see there at 10 years, the risk of progression to multiple myeloma is only 10%. So 90% of the time, you'll be fine. It's a bit different with smoldering multiple myeloma. That's the top curve. This is a diverse group of patients, and the risk varies. You can see that the risk at first diagnosis is highest. That is, the risk of progression to multiple myeloma is in the order of 10% per year. And then after 5 years, if a person with smoldering myeloma does not develop myeloma, then the risk decreases. The proof is already in the pudding. You know, the risk decreases to 3% per year. And then after 10 years, if a person with smoldering myeloma does not develop myeloma, then clearly he or she is behaving like an MGUS, even though it looks like a smoldering multiple myeloma. Now, there is a subgroup of people with smoldering myeloma who we would call high risk, and high risk being the subgroup of people with more than 50% chance of developing the end organ damage I spoke about, or multiple myeloma, within 2 years. Why is it important to recognise these people? It is because there is now active research to see whether we should address or treat these people earlier before they develop multiple myeloma. I mean, why wait until you address things? And so it's a complex slide here, but the bottom line is the way in which we identify high-risk smoldering multiple myeloma is based on 4 parameters. The only reason I'm talking about this is you can start to hear more and more about it because I think the field is now going to change to earlier treatment. So it's based on, number 1, the light chain, the level of light chain in the blood. Number 2, the level of paraprotein I spoke about. Number 3, the level of the degree of myeloma cells in the bone marrow. And number 4, the genes. Not your genes, the genes of the myeloma cells. And based on this risk score, we can calculate and divide people with smoldering myeloma into 4 groups. The first group are the low-risk group. These people behave like an MGUS. The risk of progression to multiple myeloma in 2 years is only in the order of about 3 to 4%. The second group, low intermediate. And in this group, only about 1 in 4 people progress to multiple myeloma in 2 years. The third group is a slightly higher risk, the intermediate risk group. That is, 1 in 2 people will progress to multiple myeloma in 2 years. And the fourth group is the high risk group. In here, 3 out of 4 people will progress to multiple myeloma in 2 years. And it is in this group of people who we're thinking, maybe we should do something a bit early. We shouldn't just wait until, excuse my language, shit hits the fan. So we should really address it beforehand. All right, but I want to stress, don't jump and demand treatment because until further data is obtained, the current approach for people with smoldering myeloma, including high risk, is to watch and wait. But watch this space because I think it's about to change. So what then defines multiple myeloma? Currently, we wait for end organ damage to happen before we treat. This is myeloma defining event. So you can remember it by the acronym CRAB. C stands for high calcium, R is renal, kidney damage, A stands for anemia, B stands for bone lesions on X-ray, the CRAB features. But nowadays, in people without the CRAB features, there are characteristics that can predict a 90% risk of developing the end organ damage within 2 years. And now we call these people myeloma as well. So what are these features? The first, the degree of myeloma cells in the bone marrow. So 60, if more than 60% of the bone marrow is infiltrated by myeloma cells, that's a myeloma defining event. We treat irrespective of presence of end organ damage. The second is the level of light chains. If the light chains are really high, kappa or lambda light chain ratio more than 100, that's another indication that we should treat earlier. And finally, MRI. And there are some people who have no bone lesions at all on CT scan, but MRI are more sensitive. So if we can find more than one lesion, i.e. at least two, on the MRI, then that's an indication that maybe we should treat these people a bit sooner. And so just to summarise, the new diagnostic criteria for myeloma are the crabs and the slim crab. So slim crab, S for 60% of bone marrow, LI, light chain, M for MRI. So that's what we teach our medical students. Now, Dr. Angie Yong and Dr. Cindy Lee is going to talk to you about treatment. So I'm going to paint a picture to talk about how myeloma develops, just so you can have a bit of perspective of where all these treatment lies. So you recall that I said that myeloma starts within the bone marrow. And when these guys become cancerous, the first thing they do is they develop sticky molecules on their surface, and the sticky molecules allow them to bind to the bone marrow. And when they bind to the bone marrow, there's now a communication. They then produce growth factors to establish for themselves a very fertile microenvironment to grow. The microenvironment, the so-called bone marrow stroma, can then produce blood vessels that can bring blood and oxygen to feed the myeloma cells. They also then produce growth factors to feed the myeloma cells as well. So you now see a symbiosis, a vicious cycle where you've got myeloma cell growth producing fertile soil, and in turn so on and so forth. Now, when myeloma develops, what's supposed to happen is that we have an immune cell called antigen-presenting cells. These are like your police patrol that patrols the streets, the dark streets. And these cells are supposed to recognize any cancerous cells, including the myeloma cells, and eat them up. And they're supposed to present bits and pieces of them to the headquarter immune cells called the T cells. And these T cells, now recognizing the myeloma cells, is supposed to call on a whole host of immune army to come and kill the myeloma cells. So this is what we call anti-myeloma immunity. This is what keeps it all under control. But you see, the issue with myeloma is these cells are very smart. They produce on their surface various proteins that can block the function of the headquarter T cells. They can produce all the cytokines or enzymes or chemicals that can downregulate the function of the natural killer cells. And so overall, you can see that the immune is quite impaired in multiple myeloma. And therefore, there are three areas of pathology in myeloma: problems in the immune system, problem in the fertile microenvironment, and problem within the myeloma cells itself. And so therefore you can see in the olden days all we had was chemotherapy, and all chemotherapy did was kill the myeloma cells. It doesn't work very well because you're not addressing the immune system and you're not addressing the microenvironment. Now, at the turn of the century, the drugs that many of you are familiar with, the immunomodulatory drugs and the proteasome inhibitors, they work better because not only do they kill the myeloma cells, they disrupt that communication between the myeloma cells and the microenvironment. So they work better. We are currently in the era of immune therapies, which you hear a lot more about, and we're addressing the issue of immune impairment. So you're talking about the CAR T cells and the T cell engagers and the monoclonal antibodies. I feel like I'm talking a bit too fast. I'll slow down. Am I going all right for time?
Perfect. Let me know.
Tell me, it's okay. All right. We are now heading towards another era, and that is an era of small molecules. I wish I could have some more time to talk to you about these, but these are exciting, tiny little molecules. They are so small that they can enter into the myeloma cells and disrupt the communications, the signaling within the myeloma cells, and kill specifically just the myeloma cells. So quite exciting times. And you can see that if we combine all these agents together, we are addressing every aspect of pathobiology and therefore inducing a very deep response. And deep response has been shown to correlate with better survival. So if you can imagine multiple myeloma like an iceberg, what we see is only the tip of the iceberg. So if your doctor tells you you've achieved a partial response, it means that we've reduced your myeloma burden by 50%. A very good partial response, VGPR, means we've reduced it by 90%. A complete response means we've gotten rid of the myeloma by the most sensitive test or conventional test, so the paraproteins and the light chains that we spoke about. But even when you achieve a deep response, there's a whole bunch of disease underneath the water there that you don't see. We now have a new level of sensitivity of response that is called MRD, minimal residual disease negativity. And if a person achieves MRD negativity, it means they have less than 1 cancer cell in 100,000 normal cells within the bone marrow. And so that's very good prognosis. Now, it's not until we achieve 0 tumour cells in the body that we can hope for a cure. We're not getting quite there yet, and hence we're now talking about the concept of operational cure. What's operational cure? So you can see from this diagram here that the deeper your level of response, the longer it takes for the disease to come back. And if you achieve a burden of myeloma down to a threshold, usually MRD negativity, but not necessarily, if you can get it down to a threshold whereby your immune system can take control again, your immune system can keep the myeloma under control for a long, long time, i.e. operational cure. Now, if your doctor tells you that you have not yet achieved a complete response or a MRD negativity, please don't freak out. Deep response is important, but it's not the be-all and end-all. It's the duration of response that is important. So I'm just going to give you an example of this study. This was a study that was done around 20 years ago and with long-term follow-up. And what you'll notice here on the left side is progression-free survival, survival without progression, and on the right side is overall survival. And what you'll notice here is that after 12 years, notice how the curve is completely flat. Flat means there is no more event. And what this means is that if a person has multiple myeloma and he or she achieves a response, and somehow that response is maintained for 12 years or more, it seems that somehow the immune system can overcome or regain control of the myeloma, and the person lives with myeloma, but nothing happens, like a sort of an MGUS stage. So this is what we call operational cure. Now you notice that while many of those people achieved a complete response or better, there are people in that group with only a partial response who can still achieve the same phenomenon. So therefore, deep response is not the be-all and the end-all, and duration of response is equally important. We're heading towards the end now. So I just want to point out the importance of the immune system in terms of regaining control. And this will lead into Dr. Cindy Lee's talk a bit later on. In healthy people, we know that the immune system should be able to recognise and kill cancer. And this is what protects all of us, you and I, from developing general cancer, even though our cells divide millions and millions of times. So what normally happens is, this concept actually was discovered over 100 years ago, and yet we've only come to do something about it now. So what normally happens is when cancer cells develop, the antigen presentation cells, the yellow cells, the police patrol cells, are supposed to recognise the cancer, eat bits and pieces of them up, present them to the headquarter T cells. The headquarter T cells is supposed to mount a specific attack to that cancer cells. What happens when cancer grows out of control, including multiple myeloma, is that these cancer cells produce abnormal cytokines that corrupt the police patrol. So these police patrol guys are now corrupt, and when they are corrupt, when they eat up the myeloma cells or whatever cancer cells and present it to the headquarter immune T cells, they're saying, hey, this is your friend, not your enemy. And so the T cells think, this is my friend, oof, I'll go to bed now. So these guys are not attacking the myeloma cells at all. So how does this happen in myeloma? Usually, the headquarter T cells recognise the myeloma cells through a protein or a molecule called MHC molecule, either directly or through the police patrol that I spoke about. What the myeloma cells does, it down-regulates the MHC molecule, and it corrupts the antigen-presenting cells. So we now have these headquarters T cells floating around, not recognising the myeloma cells at all. So how do we overcome this? There are now a number of immune therapeutic strategies, and you have heard a lot about CAR T cells. Sandy's spoken a lot about advocating for it. This is chimeric antigen T cell receptor. So what it is this. This is a man-made construct that consists of 2 arms. One arm binds to the cancer cells, and the other arm is connected to another arm binding to an immune cell, that's the T cells, to stimulate the T cells. And the idea is that the genetic construct, the DNA construct of this molecule is then created and then inserted into the patient's own T cells. So these T cells, now armed with the instruction, they can now make the cyborg arm, the man-made arm that can only grab to the myeloma cells and nowhere else. So how it works is that we take the T cells outside the patients, and in the laboratory we then insert this DNA construct. The DNA construct then allows the T cells to grow the cyborg arm, and then we flog the T cells and make them really angry and grow them into the millions. And these T cells are now ready to roll. They're going to attack anything that stands in their way. We infuse it back into the patients, and because they've got this cyborg arm, they can't bind to anything apart from the myeloma cells itself. And so that's how they fight the myeloma. There are pros and cons, there are side effects. It's beyond the scope of this talk, but the bottom line is that these T cells can bind to the myeloma cells independent of the presence of MHC molecule. One of the problems with CAR T cells, though, is that it can take months to produce, during which time the person may run into trouble. So there is now an off-the-shelf construct that is competing with CAR T cells that work in similar methods to CAR T cells, and these are called bispecific T cell engagers. And in fact, they are currently competing with CAR T cells. So what is this? This is another man-made construct with two arms. One arm binding to the myeloma cells, one arm binding to the T cells. And what it effectively does is acts as an engager. It engages the T cells to the myeloma cells, bind them both together, and the T cells are now forced to recognise the myeloma cells that it didn't recognise before, and when it does, it can then produce cytokines and kill the myeloma cells. So this is what it looks like under the microscope. You can see the tumour cells in green and the T cells in blue there. The T cells are connected by that tiny little T cell engager there, and you can see the T cells producing a lot of colourful enzymes there, getting ready to inject into the tumour cells and killing it. So that's exciting. In the last 2 minutes, I just want to say one thing about a personalised approach, because we are now entering an era of personalised therapy. Don't read that, it's too complex. But the bottom line is that in multiple myeloma, when we diagnose people with myeloma, we divide people into risk groups according to their cytogenetics, to the genes of the myeloma. And yet we treat everyone the same. It's a one-size-fits-all approach, which doesn't really make sense, does it? And so there is a group of people with a genetic change called a T1114 translocation. About 20%, 1 in 5 people with myeloma have this translocation at the outset. And this translocation predicts for exquisite response to a group of drug called BCL2 inhibitors. So what's a BCL2? A BCL2 is a protein that's present in every cell, and the role of the BCL2 is to prevent the cell from committing suicide. That's it. Multiple myeloma upregulates the BCL2, so it prevents itself from dying. It wants to be immortal. And usually these BCL2 are very strictly controlled. In myeloma, they're not controlled because they are overexpressed. And so BCL2 inhibitors block the BCL2 and thereby forcing the myeloma cells to commit suicide, a process called apoptosis, or controlled cell death. And examples of BCL2 inhibitors are venetoclax, and there are now a whole bunch of new second-generation BCL2 inhibitors that are exquisitely effective and, in fact, very well tolerated. And in my last slide, I just want to highlight the fact that these agents are available on clinical trials. Clinical trials are now part of everyday practice in cancer in general, not just with multiple myeloma. And in Australia, while we are so fortunate in that we have the Medicare system and the pharmaceutical benefit scheme that pays for all of us, but because there is a restriction on how much we can afford because we're paying for it, Medicare is paying for everyone, the treatment we have in Australia is good. It's not necessarily the best in the world. It's certainly not up there with the rest of the world. And so how do we access these new agents? We access them through clinical trials. And so oftentimes in clinical trials, you can access drugs that you can't otherwise access outside of clinical trials. So do talk to your doctors because the options are there, and these trials are available around all the tertiary centres around Australia. And so I think I've said enough with that. I'd like to acknowledge all our patients and carers and the team at St Vincent's Hospital and you all, and I'm very humbled to be here, so thank you for your attention.
That was terrific. Thank you very much, Professor Quach. Did anybody have a question?
Can I have a hug, please?
I think that's fronting up to HR soon. They'll call me up to HR soon at St Vincent's.
Okay. Oh.
I just wondered why
Sorry.
myeloma is increasing in the population.
Oh, what a wonderful question. That's good. Why is the incidence of myeloma increasing? I don't think it's anything to do with the biology of the disease, but I think we are now more aware of it. People are now detecting more people with MGUSs, so we're now monitoring people closer. There may or may not be some environmental factors, but we don't know. And it's increasing not just in Australia, it's around the world it's increasing. Thank you. It is done in Australia. In fact, there are a number of hospitals around Australia that are already testing for MRD negativity. But I want to qualify that by saying this. The reason why a lot of us don't measure MRD negativity routinely is because there's nothing we can do about it, because we're limited in what we can give patients. So MRD negativity, it's a prognostic factor. Prognostic means if you achieve MRD negativity, that's great, you're going to do very well. But say if you lose that MRD negativity or you relapse, our options in Australia is so limited in that, well, if we're not going to do anything about it, the cost of doing an MRD negative is like $900 or between $500 to $900. Can we afford to do it when it's not going to change what we do? And the answer is no. In the future, however, we need to push for measurements of MRD negativity, because I think it's going to direct care, in a person who achieves MRD negativity, say, for 12 months. Should we then stop treatment? Or should we continue treatment? That we don't know. How it impacts treatment is something we have yet to explore, and there are now active clinical trials around the world, including Australia, to explore an MRD-directed approach. And until the results of those trials come to fruition, we don't know what to do with our MRD negativity, and that is the reason why it's not routinely tested. But yes, it is available.
Thank you very much, and here's a little gift.
Oh, thank you.
And
Thank you.
certificate.
Thank you. Thank you very much.
Thank you.